here. I don't see her. Okay, welcome everyone. Today, we want to welcome everyone. This is a group of clinicians, the I-CBT Friday discussion group. We are all clinicians in different stages of learning I-CBT. And this has been a wonderful space for learning together and contributing to each other's work and sharing our experience with OCD and I-CBT. Thank you for being here today and for being a part of this group. My name is Silvina Levene, and one of the co-facilitators for these discussions, along with Mary Hosbrough and Margaret McCall. We are currently running a series of panel discussions focusing primarily on how to present the I-CBT modules to our clients. After the presentations today, we will be opening the forum for discussions for all the attendees. And we would ask that all participants refrain from sharing clinical specific information about their clients, as this meeting will be recorded and hopefully available in the I-CBT website. I know we all want to thank in advance to our wonderful presenters for so generously sharing their time, preparing for this presentation and sharing with us your knowledge and experience. We will be presenting module 1, and our presenters will be my Heady, Theresa, Chiu, and Lynlee Olivera, hopefully she gets to join us. So perhaps this will be a good time for our panelists to introduce themselves. With Theresa, would you like to start?
Sure. I'm Theresa Chiu, and I'm an LICSW in Washington State and LCSW in Pennsylvania. I have OCD myself, and I treat my entire private practice is treating OCD, and I've been providing I-CBT for quite a while, since last year, and so I've got lots of experience actually seeing its change for clients. And today I'm looking forward to sharing more information on Module 1. I'm really happy to be here, and thank you to our hosts and everyone who's been helping move I-CBT into more mainstream spaces. So it's great to be here.
Thank you, Theresa. That's wonderful. We can't wait to hear you. Mike, would you like to tell us a little bit about you and your practice?
Sure. Everyone can hear me? Hi, I'm Mike Heady. I am the co-director, co-owner of the Anxiety and Stress Disorders Institute in Maryland. I came to I-CBT, it was before the pandemic, but I really dove into it seriously at the beginning of the pandemic. Introduced it, Carl Robbins, who's my coworker. There are actually several ASD associates here, I think. Hi to you guys. Introduced it to me probably 4 years ago. It's hard to remember. And I treat most of my OCD clients with I-CBT first now. And then we move into the ERP if we need to, or to other things. And I'm happy to be talking about Module 1 because I think it's a critical module. And I think there's a tendency for people to gloss over it. And I'm hoping to convince people to not do that. So,
yeah, thank you. And Lynlee, thank you for joining us. Would you like to share a little bit before we start about yourself and your practice?
Yes, thanks. Hello, everyone from wet and rainy California. I am an LMFT in private practice. And I enjoy working primarily with OCD. I was in the middle of BTTI, or toward the end of it, when I saw an email connected to the OCD ERP Facebook group pop up, and it so intrigued me. It so intrigued me, and I immediately joined. I think there was 100 and something members at that time. And it was just the beginning of a huge shift in my treatment and my practice. And I do try to start that way with my clients. And I'll enjoy talking about that transition over with clients that I had when I did make that change. I think that was a big deal, or a big step for me in learning. But I'm so happy to be here, and I can't say enough about the camaraderie, the compassion, the openness, the community that this group, it's just exceptional. It's unique, and I'm just thrilled to get to be a part of it. So thanks, glad to be here.
Thank you very much. I just noticed that Mary shared some resources for everyone, the I-CBT website, the consultation groups, and the clinician's manual for everybody to have as resources. And well, without further ado, we can probably start with the presentation of Module 1. I don't know if which clinician would like to take the lead on this today.
I vote Theresa.
Mike, when I saw you come up to talk, I was like, I was just going to vote for him.
Ladies first, I would say. Very gentleman of Mike.
Well, I mean, you know, I submitted a 40-minute video to the I-CBT Facebook group. So I really, last night I was actually chatting with someone about how, you know, what do I want to present in 10 minutes here? And I'm okay with just kind of being more or less here to answer questions, if that's okay. And, or, you know, maybe something will come up as we go, but I don't know if I need to really like present again here. I just wanted to see like, if maybe I can be here as someone who can answer questions if anyone has any specifics. So Mike, I'm voting you to go first.
That was an artful pivot. I appreciate that. So here's my presentation. Watch Theresa's video, and we can all break for lunch. So I think, you know, Module 1 is somewhat self-explanatory if you just go through the manual, if you go through the free paperwork that's available online. It's pretty straightforward, and it's pretty easy for clients to understand, I've experienced. So on its surface, it looks just like psychoed, right? On the surface, it just looks like we're helping the client orient themselves to where the problem begins, which is the doubt, and we're giving them a structure, which is the sequence, and that's nice. But I think it does so much more than that, right? Like, it's super important. If we think about sort of like what we're communicating to the client with Module 1, the first thing that comes to mind is that it completely reduces the overwhelm that a client can experience. And the book goes into this, right? That people with OCD can feel completely lost, overwhelmed, bewildered by their experience, because they could have hours of compulsions that carry on, obsessions that can then chain into other obsessions. It can be really complex. And to give them some kind of conceptualization framework that then simplifies it is incredible. It's quite an intervention in and of itself to do that. And then to help them understand that it not only loosens up that overwhelm and that bewilderment, but it gives the client a focus, an orientation of where the problem is, right? It begins with doubting, right? And they've probably read or been told or experienced the problem to be about anxiety and fear and shame and avoidance. But to think of it as an upstream doubting process that sets it all in motion, And so module 1 gives us that framework that this is a doubting disorder from the get-go, and that this is where the problem lies. And the other thing I think it does pretty artfully is it gives us a sense of OCD occurs in moments. OCD is provoked episodically. OCD is a here and now problem, right? It's a disorder of the here and now. It's not a disorder of some abstract future possibility that we all have to learn to just make room for. OCD is triggered by something in the present moment, and then we react as if that thing is relevant to our reality or is in fact real in the present moment. So it really helps us orient towards when this is occurring. Again, all of this reducing a sense of bewilderment, giving an organization to the process, and focusing on where the treatment, at least from an I-CBT standpoint, lies inside of or at the point where we're doubting. So module 1, I think, is so much more than just psychoed. It's more than just, can we get the client to understand that there's a sequence to these processes? Can we get them to understand it begins with doubting? Can we get them to apply it to multiple different presentations of OCD, whether it's their own or other people's? I think it sends a much more nuanced message than that, which is why, like I said before, we don't want to gloss over it as purely this thing to get through, right? Like, let's get through module 1 so we can do the real work. This is where the real work begins, and everything is built upon this. So that's my short speech about module 1. We can let Lynlee take over from here.
Well, it would have been easier to done a video like Theresa did, so I didn't have to have this pressure. I think that's a great lead into what I wanted to say. And it's interesting to me that Mike would say this, because I'm still learning. I'm still figuring this out, and it resonates. What Mike just said resonates. So I was thinking about, I don't have OCD, and it took a while to learn how to treat OCD with ERP and ACT. I remember having aha moments, learning those techniques, and it was my clients that really taught me, that really brought it home. So this idea of something being nuanced, there's so many parts to it that help it come about. So I think when coming over to I-CBT as a newbie, I remember the initial thing that I learned or heard was, there'll be a trigger, and once the trigger happens, you want to prepare yourself for the possibility that you're going to be pulled toward this doubt and this black hole that takes you into the rabbit hole, whatever. And when you get good, this is just my initial memory of what I remember, or you can learn to identify that at the trigger is where you need to have awareness that you're going to experience doubt. And that was what my takeaway was for a while as I was learning. Then I got the handbook, and I felt very overwhelmed because it's very meaty. It's really dense reading. And I saw therapists coming along saying on the Facebook group that they were taking on new clients with I-CBT. And I thought, how could they do this? And so I was patient, and I know I'm getting to the first module, but I feel like this is part of the first module for a therapist that's learning or considering that they're going to begin using the first module. So using the first module for me has been, of course, all that I said, but getting the courage up as a therapist that used to know how to, or I thought I knew how to help my clients, taking that risk, that step into the unknown, just like my clients have to do this hard work. I was having to put myself out there and invite them to be a part of that. And I know we've talked about that before in other Friday meetings, but that's been an important part, especially if it's someone that's been doing ERP and we're shifting. There has to be so much care in why we're making this shift. And in the beginning, I didn't know why. I hoped that it was going to make sense. And I think I'm off of what happens in the first module. This is more about my learning in the first module, my learning, stepping into it. And maybe I have a little bit to say about the first module, actually. What I've been noticing is that as I've taken these steps and risked that, not knowing for sure how it was going to turn out, it's been just such a wonderful, it's unfolded. It's made sense as I've taken step after step. And I have to agree that I remember looking at the sequence, the doubt sequence, and thinking, this is all well and fine, but I can't tell a client just do this and this. It's coming back to that and gathering the lessons and coming back and checking in with module 1 and talking about the bubble and coming back to module 1. So I have to say I really agree that that gets worked out as you go along in the treatment and in learning the modules and finding out about people's trauma that comes along and their stories that they have, and how does that fit into the OCD doubt or the reasonable doubt in their life, coming back again and again. I hope for anyone that's new, if you want to reach out and ask me more about that, but for me, that's what's coming up right now, talking about the first module. After Theresa and Mike talk some more and people ask questions, I might think of other points, but that's what I got right now.
I would like to thank you, Lynlee, for sharing your experience as a growth experience with the client in the process of learning something new. And we all do that with every client, even if we are, even if we are experts on something, each client is a new client and the presentations can be so different. So I personally appreciate you sharing that. I like what you said, that you use the first module as the anchor you always come back to touch base in the sequence and enrich the sequence from the other following modules. And kind of that resonated with me when Mike said that first module is what really anchors the client, as opposed to just in 1 second I'm compulsing. There's something that happens in between that you can slow down the process.
And also along the way, it's been these lived experience clinicians, primarily, but not exclusively, who have shared things about this that have, it's in my head, it's been a check that really helps as we're going through and learning. We I've been relying on that, and it has been incredibly helpful. I think I had a chance to talk to Theresa about that there was early on a couple things she said, and it was just spot on what I needed.
I love, Lynlee, how you're bringing in how this is for clinicians coming in to I-CBT and treating OCD using I-CBT. I wonder if I am interpreting correctly what you were saying is kind of like you were doing the modules even though you weren't really sure what it was going to do for the client. and then it kind of was like, oh, light bulbs going off even for ourselves as clinicians, right? We're going through and we're kind of like, I don't know if this is going to work, but let's do it. And then for the OCD brain, it's like, this makes sense, you know? So a lot of us clinicians with OCD, we experienced that. So we already knew what we were trying to do with our clients. You know, we had that experiential understanding. And so I think that's really nice to point out for clinicians coming in is it's like, it is such a gift to have these modules because they might seem very like, you know, we might feel like technicians. We're like following this, you know, this module here. But it really is a way to kind of help us have that structure until this clicks as well for us. And that, I think that's okay, because, you know, we don't have to have all the light bulbs before we can help. You know, you have a general understanding of what we're trying to do here. We're trying to resolve doubt. And in that video that I did with David, we did the little experiment. You know, he opened the drawer and he closed it. And that can be very profound for clients because it's like, oh, I knew it was shut, but now I'm doubting it a little bit. I'm the little external prompt. And, you know, these are like just little nuggets along the way that are going to help the client resolve that inferential confusion. You know, so I do agree with Mike. I think module 1, even if it seems simple, it can be very important. Like, I think it's such an important module. I do use it even when I provide ERP because I want the clients to resolve that obsessional doubt. And I think that it gives us a nice little structure. If you want to follow the module, but there's room for flexibility. Once you understand what you're trying to do with your clients in this treatment, we were talking about this in the pregame, make it an art. You know, this is, you are the clinician. Adjust it so that the client can understand what you're trying to help them understand. And you're not telling them, but you're guiding them. You're helping them experience this shift. And I-CBT modules give us a foundation for that, a framework for that. But there's flexibility there. And I was talking with Fred. He reminded me and made a good point that we don't have to get through the whole module in one session. In fact, sometimes all I get through is an obsession comes before a compulsion. Sometimes that's where we go. So, and that's okay. We don't have to go from, you know, the beginning to the end in one session. This is going to be used throughout the treatment. So it's important to bring it in as you can. Sometimes you're using colors. Sometimes you're not using the module. You're not showing them words. You know, follow your clinical judgment on how to help clients understand how we get doubts to grow. Help your clients understand that they don't just have a consequence. There's stuff happening before. Whatever creative way you need to find to make this point with your clients, use that. And that is the treatment. That's part of the resolution.
So I've seen a couple questions come into the chat, and one of them might have been answered within the chat already as well. So let me scroll back up. But Amy was asking, how do you help a client choose a doubt or series of doubts? And then Margaret mentioned that the module mentions, you know, picking a couple of the most distressing or prominent doubts that are bothering them the most. And then also any tips or questions to help clients and clinicians get to the primary inference. So I'm wondering if maybe you could even speak a little bit about what we mean by primary inference and then how to get to the primary inference.
I have I had something came to my mind. I used a screener tool recently with a new client. And that's, of course, one way to, this is somebody that's never had treatment for their OCD. So I wanted to be sure that I uncovered maybe some other thinking that they were having that perhaps they weren't aware of, to help, have a little bit more preparation for the treatment. But there's also, and I'm not sure if this is what the question is, but what came to my mind was someone recently telling me, oh, I know, after I had talked to them about the wonderful aspect about, I'm not talking about the first module here, but the wonderful aspect of I-CBT is that we do want to know about where this doubt was rooted in, or, if there's a connection there. And after a period, I did have a person, say to me, oh, I just realized why I have to suddenly check that my grades are, that my grades are the best that they can be, or that I'm doing everything I can to make sure my grades are good, even though this is an excelling college student. It's because what I experienced growing up with having strict parents. And they spoke more about that, but that came from the client. I gave them enough information about this treatment and this process. And of course, this happened in module 1. And they were able to give that to me. They connected the dots. And of course, I was delighted and thrilled because I'm still learning. And for me, it's very confirming that what I'm doing is I'm on the right path here. But I don't know if that's answers. There's different ways to try to get to the main nugget of the focus. And I'm not sure if I'm on track with that or not.
I'm also thinking about, and yeah, thank you for that, Lynlee, and maybe Amy, if we are not answering the question, then let us know. But I'm also then thinking about, when I think of the primary inference, like someone might have like, did I lock the door, would probably be the primary inference. But then in the discussion, they get caught up on, there's this other doubt, like what if I have an intruder come in my house? What if my cat gets out, or whatever? Like those things, the things they're getting caught on, those are really the consequences of the doubt. And so how to bring them back to, if we solved the primary doubt of, if you knew you locked the door, then you wouldn't have the consequences of the doubt, which are more of the, and let me know, I think, Theresa, if I'm getting this right, or Mike or Lynlee, those are more like secondary inferences, or more like the consequences. So when someone is caught up in the consequences, how to bring them back to understanding the primary inference of the doubt.
Yeah, I think that's how I would look at the question, at least as the book references primary inference, is that we sometimes get caught up on the consequence that my house could get broken into, my cat could get out, something bad could happen, the house could burn down. These are consequences. What would need to exist for that to occur? I would have had to leave my stove on, the door unlocked, the door open, right? And so that's what's being doubted. And so the primary inference is the thing that made the consequence feel like it was relevant to you. And it was that doubt showed up. So when we're talking about primary inference of doubt, that's really what we're trying to get at. And we can often sort of reverse engineer or back up, starting with the compulsion right? The person stares at their door lock for 3 straight minutes to make sure it looks like it's locked. They're doubting the door's locked, right? That's why I'm staring at the door, even though their consequence might be described as the house, someone could break into my house. So that's what we're really trying to trace it back to is what doubt or what circumstance or what context would need to be present in order for that consequence to be relevant. It would have to be this. Okay, so you're doubting that. Does that answer the question?
I'm noticing that Margaret has a question as well, but I would like to ask you a question directly with you were just saying. So is the primary doubt the first that shows up, or is the primary doubt I would be the person who is responsible for hurting all these other people? Is like more related to the vulnerable self theme, or is the first doubt showing up? I'm not clear on that question.
Theresa, did you want to field that question?
Sorry, I was in the chat. I missed the question.
Oh, the question was if the primary doubt is the first doubt that shows up, like, oh, what if I lock the door? Or is the primary doubt or the primary inference that I am the person who will be responsible for other people's harm? Is it related to the self-theme, or is it the first thing that shows up, the surface?
So yeah, actually, it's a really good question. So I made a visual of this because it comes up quite a bit, and it's actually let me share my screen so everyone can see this here. The iceberg. Can you guys see the iceberg?
Mm-hmm. Here.
Can you guys see the iceberg?
Yeah, it's wonderful.
Yes.
Yes.
Okay, so here's the iceberg. And this is the primary inference of doubt. So this is the what if my hands are dirty? And so this primary inference, this is the obsessional doubt. So it's the same thing. It's a conclusion. Okay, so an inference is a conclusion. And this conclusion is an obsessional doubt conclusion. And this doubt is actually kind of like informed and formulated. So it's arrived at because of that story, because of the reasoning, the faulty reasoning, the vulnerable self-theme, the distrust of the senses and reality and common sense. So all of that like put together, we don't really like separate it all. It's all like inferential confusion is that like these go hand in hand. It's about getting caught up in possibilities and not being in reality, and not trusting the self and that vulnerable self. And so all of this goes together, and we arrive at this doubt. Now keep in mind that the obsessional doubt, that's the primary inference, and then the consequences and appraisals can be thought of as like the secondary inference. But the doubt is almost always about right now. Okay, and then the consequences, those get a lot more future trippy. So when you're working with anxiety disorders, a lot of people kind of like, it's about tomorrow, like it's, or the future. This will happen over there tomorrow, not right now. And so in I-CBT, we're saying, well, OCD is a problem about right now, like a doubt about what we already know right now. And then that future trip where we're like, I'll get sick, the house will burn down, bad things will happen. All of that is in the future. And yeah, we don't have certainty on that. We can't guarantee tomorrow, but that's not the problem in OCD, according to I-CBT. The problem is right now, we're doubting something we already have the information about. So that's the difference, is the doubt is really, it's almost always going to be about right here, right now. What if my hands are dirty now? If they are, tomorrow I'll get sick. So anxiety disorders kind of hang out more here, in my opinion. But OCD, in order for it to be kind of like that delusion, we have to have a knowing now. And it's not a full delusion, that we still have touch with reality, but this is what we mean when we have that certainty, like right now we know. Does that answer that question about the primary inference?
Very much so. Thank you. Now I see that Margaret has been very patiently waiting for her turn. I'm so sorry I cut line.
Get that prerogative. You're in charge today.
Yeah, I figured I took the license.
Thanks, Sylvie. So I have a kind of a nuts and bolts question. With ERP, I always started with assessment, and we did the functional analysis, going through the Y box down each of the lists. And when I started I-CBT, I kind of did the same thing, except that functional analysis was the assessmental sequence. And so that takes a couple of sessions at least, because my mind still sometimes operates ERP. We've got to know you don't want to leave any piece of the cancer out, but that's not quite what, you want to know every obsessional doubt. I still operate not under that framework, but I do the sessions with starting out with going over all of the Y box, getting it out, getting on the obsessional sequence. I'm curious what you guys are doing if you're integrating, and I do integrate the obsessional sequence in that, not the full module 1, because we start that after the assessment and after we do the severity scale. But I'm curious how that flows for you leading up to module 1 and when you introduce these concepts, if you do it, start with assessment.
I mean, I usually start with assessment or various conversations that I've had with clients on the phone or email beforehand to get a sense that this is likely OCD. And I'll give a Y box, or I'll give a different screener tool that helps me get a sense of the theme or the orientation of their OCD. But usually I get that through a conversation, 15, 20 minutes on the phone with a client before they come in for a consult. First part of the consult's usually diagnostic background information. And then if we shift into the end of the first session, maybe we'll introduce the sequence, and then we'll spend most of the next session on unpacking the sequence. And that's typically how I like to work it through. I mean, I guess it really depends on the client that comes in. Client with panic disorder, social anxiety, OCD, and trauma is going to take a little bit more up of that first session.
Thank you. I'm thinking I spend too much time these days doing that very thorough assessment, because what I see is it generalizes to the other stuff anyways. I need to know the theme, and I do too. I'm an OCD specialist. I rarely see anybody who doesn't have OCD. So I've screened that all out before I even had that first meeting. So I know they do. And I also know their theme, but I don't know. I was just wondering, I'm probably wasting too much time. It'll come up later if there's something I missed, you think?
Well, I think there's also the benefit of rapport building by understanding the client's experience. So if you're going through the Y box, you're getting a ton of really personal experience that they're having. And what a great thing to sort of, show that there's no shame involved in that, it's completely normal. This is like the 10th time I've heard this today. And,
with that?
So yeah, I think there's value in going through all of that. I don't know that it's like required that every single potential obsession a client has, because they don't always tell us that on the form or even 3 months into treatment.
Thanks, Mike.
I was just thinking in relation to that, if you were to review all the obsessions and compulsions the client has, if we're going to plug into one of those or two of those into the sequence, is there something that we should consider as like the level of distress that we start with? Should we start with something that is highly, highly distressful? Should we go like something in like a level 4? I'm thinking like, are we using that in a ladder like we do in ERP?
That's a really good question. So it really depends when I'm working with a client. Sometimes because I have worked with clients who come in with extreme, and so their Y box is very high, and there's a lot of discussion about the consequences, right? Like that's where they're at. Mm-hmm. And that keeps, they keep talking about, this is really bad, Mm-hmm. And so what I do is I will use a little bit of like a gentle kind of like, let's put it into the sequence. Let's put this in here. So if they're already in that zone, we can just sequence it out together, and it can be very validating. I mean, it can actually kind of stop the bubble in a sense, because I'm not saying like, I'm not agreeing with, the consequences and all that, but I'm just really like kind of coming in with a curiosity, like, what does this sequence look like? Let's put this in here. So add the house that burned down. Well, that lands right here. What's coming before that? What's the what if before that? Get some kind of like, okay, curious mind. Now we're looking at the sequence. If I'm working with someone who has lower suds in the session and the Y box is, I mean, they're going to work and, they're doing pretty well, but they are still suffering. I just kind of ask them, like I did in the video. I said, have anything you want that you've had today, maybe even in session, that we can throw into the sequence, and then we just put it right in. So I don't really have to like look very hard. Right? A lot of times I can see that my clients are anxious even just talking about it, and I say, well, is there a doubt now? Can we put it in the sequence? And so if you're working with someone, this was something I actually did want to share today. If you're working with someone who has really high suds in session, and it seems really challenging to change anything there, I think that you can just pull up the sequence. It's a little bit of it. You don't have to interrupt them too hard. Do it gently. There's a lot of suffering and it's very scary and they're very scared. But you can kind of just gently nudge it back over to the sequence, have the visual there for them. And you might be the only one kind of like moving this toward the obsessional doubt, and they might go right back to the consequences. Okay, but that's okay, because the next session, they might remember that, right? That is some of the work. So you're laying some foundation there. And the next session, they might come in and they might be really focused on the consequence again. And you can just kind of say, oh man, that is really scary. What came before that? There was a doubt, so let's identify it. And you're continuing to kind of move it back in that direction. And if they do need a higher level of care, you got to consider that, right? But if you are meeting with them kind of like in an IOP setting or something like that, I think you can keep doing that in a creative way, in a very kind and compassionate way. And it does eventually click. Like I've had success providing I-CBT to extreme symptoms. So it can be done.
Very client center, like you're saying. If the client is there, why not go there?
I really like, Theresa, how you describe it as it's very organic and free flowing. And that's getting back to Sylvie's question. And originally, I just want to agree that is, it's going to come out at one point, whether you're on the right, the inference or the initial, where did it start? It will come around as you learn more about the client and their coping strategies to function in all ways that they might be doing that. Eventually, with time, it gets uncovered. So that's been a really fun thing. I just wanted to say I loved Theresa's future trippy and her iceberg diagram. That's awesome.
Leads to good treatment.
Correct.
Yeah. So Lori, would you like to share your question or comment?
Sure. I mean, this is a little, actually it's off track, so I wanted to come at the end, but I think Theresa had mentioned something about a higher level of care. My dilemma is the higher levels of care are all ERP based. And if we've been doing I-CBT and somebody is very severe, I've been a little hesitant, especially with, I don't know, say POCD or something, where they're going to go and do a lot of fear scripts and become more immersed in the obsessional, in the bubble. So I just didn't know if anybody knew of any I-CBT intensives or what you do in that case.
Somebody posted in the group that they're starting an IOP. I'm sorry, I can't remember who it is, but if you look in the group chat,
Okay.
Yeah.
one of our people is starting one.
Oh, that's great. We need more of that.
Yeah, definitely.
Yeah. Lori, what I do is I just, I prepare the client. I say, look, there's a few different effective treatments. This is what they're offering over there. You can give it a shot, and it actually drives my advocacy. So what do? I advocate like hell, and you know, keep doing that. It's motivation for that. So I appreciate your your consideration for that and how much this is, I think, is needed and a very important part of OCD recovery for so many people.
Yeah,
So,
absolutely.
yeah. I wanted to answer Julie's question in the chat, if that's okay, regarding POCD. So sexual themes, if the person, they said, you know, when I'm doing the doubt sequence, I just ask the client, you know, like they'll let me know when I have a doubt when I'm watching TV. And so that's the prompt. And then I ask them, like, you know, what's the doubt? And they might say, I'll be off to jail. And I say, well, that sounds like a consequence, right? Like, what's the doubt in that moment? And they say, and they'll usually be able to answer it pretty easily. And it'll be something like, what if I like what I'm seeing? What if I'm doing this on purpose? What if, you know, what if I'm getting turned on, right? And so they can usually identify that, and it's going to usually be in the present moment. So if it's a future trip, you can, that might be an indication or a clue for some clinicians. Okay, this is a future trip. There's something that's happening in that moment, and that might kind of help you come back to finding what is that what if doubt. And I usually just say, what's the what if in that moment? They're not going to say, what if I go to jail, right? They're going to say, what if I like what I'm seeing? What if I'm really looking at the privates, right? And that gets them coming back to the present.
Thanks, Theresa.
This is very helpful. You guys are great. Thank you.
I think we have only 2 minutes left. If anybody has a last minute comment or question. Margaret, I see your hands up.
Well, don't let me take someone else's question. It's a follow-up. Does anyone else have it before I ask? I can get my answer elsewhere. Okay, so this one's to Mike again. I thought about what you said, Mike. When you do the assessment, when you do the Y box, do you use the screening Y box as your Y box and then do the severity scale, or do you go through the full-blown Y box prior to starting treatment, or anyone else?
I wish I could say I had like a thing I did that I just like copy and paste with clients, but it really depends on, like, you know, if I talk to a client, they really get their OCD on the phone and like they have a lot of insight, I'm probably going to spend a lot less time. I might do the severity, I might do the symptom checklist and just get a sense of what's going on. But if I feel a little bit lost, if there's information I really want, I'm going to do the full Y box. And maybe even some other measures of BDI. I'm going to get a much bigger picture, ask questions about sleep. I just want to get a sense of what I'm looking at. But it really is idiosyncratic. I don't follow a thing I do with each client.
So what you're saying is you trust yourself to know what to do.
That's a nice way of framing my my disorganization.
I'm working on it, Mike. I'm getting there.
You're creative.
Yeah, I wonder if it would be helpful to put some of those resources, like if you're confused, go with this one. If it's very clear cut and the client has good awareness, go with that one. I don't know if we can share some resources in the Facebook group.
I love the OBQ. I think it's great.
Well, it's 2:00. This has been a wonderful, really a wonderful, for me, has been incredibly insightful and learned so much today. I hope every other clinician feel the same, either new ones or more experienced one. And we want to thank again Theresa, Mike, and Lillian for their wonderful contributions and insight and generosity and vulnerability as well. Thank you very much.
Thank you.
We'll see you next week.
Thank you, everyone.